Welcome to blackdoctor.org. I'm your host tonight, Shamika Rhymes. Let me know in the chat where you're watching from and how you're doing this evening. And make sure you share this with your network. And if you have any questions at all tonight, please drop it in the chat because we definitely want to hear from you. So today is World Sickle Cell Day. And tonight we're taking a closer look at the realities of living with sickle cell disease in the Black community. And as you've heard, and even last week when I did a show on sickle cell about celebration. Goodness, sorry. We're a group of people that are disproportionately affected by this chronic and often misunderstood condition. So we've got a panel of experts here tonight, and we're going to explore the unique challenges faced by individuals living with sickle cell, especially those navigating their day-to-day life. We're also going to talk about what to do during a painful crisis, options for care, and the importance of lifestyle management, including practical tips that can help reduce complications. So this is a conversation on awareness, access, and advocacy. So let me introduce you to tonight's guest. So joining us from Cedars-Sinai Medical Center, Dr. David Gibb is an assistant professor in the Department of Pathology and Laboratory Medicine and the Division of Transfusion Medicine at Cedars-Sinai. And as a physician scientist, his research focuses on inflammatory mechanisms that influence the alloimmune system response to red blood cell transfusion, which are common and detrimental in patients with sickle cell disease. So let's welcome Dr. Gibb. Hi, Dr. Gibb.
Hi, thank you for having me. Happy World Sickle Cell Day and happy Juneteenth. I'm looking forward to our discussion.
Me too. We've also got Dr. Nicole Baca. She's a pediatric hematologist oncologist and assistant professor at Cedars-Sinai. She received her medical degree from Ross University School of Medicine, and she, like I said, specializes in pediatric hematologic oncology. She's using novel MRI technology and artificial intelligence to see if we can accurately predict which patients may have a higher burden of benign tumors or malignant transformation in the future. Let's welcome Dr. Baca.
Hello.
Hi, Dr. Baca. Welcome.
Yeah, thanks for having me here. It's going to be a fun conversation. It's definitely an underserved disease, so it's good to get it some publicity and get it in the news and have it on the forefront for research and growth in this area to help these folks that unfortunately have this disease.
Absolutely. And we also have joining us Christian Brown. He's an experienced community leader, patient advocate, social scientist, and entrepreneur. And the Oakland native has been recognized by the Global Food Justice Center of Expertise for his commitment to making cultural staple foods and nutritional supplements available to members of the sickle cell community in the form of health packages at no cost through his Creation of Society platform. So let's welcome Christian.
Thank you. I'm very grateful to be here and have a seat at the table discussing this very serious and very complex genetic mutation.
Yes, thank you all for joining us. And again, for the people in the chat, please drop any questions that you have because we want to make sure we get all your questions answered tonight. So I see there's quite a few people in the chat already. I see Gastonia, Cedars in LA in the chat, Asheville. Welcome, everybody. All right. So is everybody ready to get started?
Let's do it.
All right. So this first question. This is for both Dr. Gibb and Dr. Baca. What is sickle cell disease and how does it affect individuals who have been diagnosed?
Okay. So I can take it away. So sickle cell is a gene mutation. It's common in sub-Saharan Africa. It's also common in India, and there's populations like Hispanic populations in Southern California that also carry this mutation. It's a point mutation, meaning it's one AT substitution. It's actually in codon 6, so it causes just one glutamic acid to valine change. So it's just one tiny little change that causes so much havoc on the body and throughout the world. And it's, when you think back to like high school biology, like, well, why has this persisted? Well, there's evidence to show that it is protective if you only have one copy of this against malaria.
Mm-hmm. Wow. Well, what is the difference between sickle cell disease and sickle cell anemia? Is there a difference? No?
I'm not aware of a difference.
Okay. Because I think sometimes we hear both terms and it sounds like they're both
Right.
kind of interchangeable. Let's see. We've got more people checking in on the chat from Los Angeles Metropolitan Churches. Hello, y'all. um, well, what is the, let's see, sorry, I can't see these questions. What is, sorry. Let's see, we talked about what sickle cell disease is, but how does it affect individuals who have been diagnosed? Is there, and how are they diagnosed? I guess that's the biggest question. Like, how are they diagnosed? Dr. Baca, can you answer
Yeah,
that one?
I can take that.
Okay.
So in the United States, they should all be caught on newborn screening. The newborn screening that started looking at sickle cell disease was initially in the 1970s, but I believe it was not in all 50 states and the District of Columbia until like 2007. But it should be something that's caught. And California has a pretty extensive, there's also a large thalassemia population, which is different disease, but kind of similar different changes that happen in the hemoglobin. So they're very, very extensive testing that's done here. We're pretty lucky. So these kids should be flagged on that screening, and then additional confirmatory screening will be done on these the blood that's just right out from birth. The only time that it wouldn't be accurate is if someone had intrauterine transfusions, but you're going to know about, like, that's a big deal. You're going to know about that if that happens. So they're very accurate testing, and we're able to make these diagnoses in very small babies, and able to start doing some of the preventative medicine within weeks to months of life.
Okay, thank you. But do we know why sickle cell disproportionately impacts the Black community, especially? Is there research that explains that?
Yeah.
I mean, Dr. Gibb?
Right. Yeah, I think it's sort of what Dr. Baca mentioned previously, is that the genetic mutation has been persisted because of its role in malaria protection, and malaria is very endemic in Africa. So that's sort of why African Americans have been mostly affected, and also when people of African descent, so people in the Caribbean or in Latin American countries who have a distant history of family members, from the African continent where malaria was endemic. That's why, it's almost all of the patients are of African or Caribbean or sometimes Hispanic, but rarely Hispanic, I would say, ethnicity. Yeah.
Okay, thank you.
I can also well, sorry to jump out. I think you asked about complications for patients with sickle cell disease. So I think some of the most common, and why the newborn screening is so important, is that stroke is a very the most serious, I would say, complication that can happen in childhood and throughout adulthood as well. But so it's very, it's needed to know whether they do have sickle cell disease, so we can take measures to prevent that. There are other complications. So vaso-occlusive crisis, also known as pain crisis, is extremely common. One of the main reasons why patients with sickle cell disease come to the emergency room. Sickle cell disease is very painful because of all the vascular inflammation and the basically the closing of the vessels, that supply the organs and the muscles and the nerves. And there are also other complications that can happen. So something that's called acute chest, which is basically when patients have vascular occlusion in their chest around their lungs, they have a lot of chest pain, and as well as have trouble breathing. And this can be really serious, and can be fatal. So these are some of the major complications. There's also just sort of generalized organ dysfunction, which is another, if if they're having trouble getting oxygen and red blood cells to the kidneys, the liver, the lungs, heart, etc., that can also happen. So
Mhm.
lots of many complications that can happen, and I guess we may talk about treatments later. So
And
Okay.
infection risk, yeah, and increased risk of infection. They start antibiotics as soon as we can after we
Mhm.
confirm the diagnosis, within weeks to months, preventative antibiotics.
Okay. Christian, can you share with our audience your journey as a parent advocate for your child who's been diagnosed with sickle cell anemia?
So my journey has been very rooted in duality, in the
Mhm.
sense of being in the Western world, where the whole foundation of Western medicine, science, and institutions are really grounded in eugenics. And then the whole idea that we have another group that is following the footprints of Linus Pauling, who was also a eugenicist as well. Um, and he coined sickle cell being the first molecular disease. And one of his goals was to tattoo a symbol on the foreheads of everybody who had sickle cell trait as a way
wow.
to prevent cross pollination or reproduction. So I think Western institutions are a very powerful force, and I feel like they impose a very powerful presence on the lives of not just the sickle cell community, but also the descendants of enslaved populations here in the Western world. So, to take care and provide for a child who has sickle cell, you're met with a lot of hostility inside of the hospitals, especially with the standard of care. I just recently listened to an interview with Jennifer Donda when she said that she wants CRISPR to be the standard of care for the sickle cell community. But Matthew Portis has already suggested that that actually sterilizes the patient
Hmm.
through, through the white blood cells, through the chemotherapy. So here we have CRISPR being rolled out as a cure for sickle cell, but it can sterilize every person who goes through that process. So the foundation of eugenicist rolled out into the sickle cell community directly corresponds with the original impact or our sharing proximity with European migrants from the very beginning, which is why we have to celebrate Juneteenth today because of that sharing of space. If we look at the black farming population here and think about sickle cell anemia, anemia being a nutritional deficiency, while sickle cell being an adaptation to malaria. And if we look at the plight of the black farmers from the 1860s, where they had about, after the Civil War, close to 20 million acres. And within a short span, less than 100 years, the federal government through the USDA has stripped 95% of that land um, from black farmers in the black community. The black community at large has the highest health disparities, not including the sickle cell community, because we're eating at a European standard. So all these systems are connected. So taking care of a child who has sickle cell, it's similar to just the black experience here in the Western world, which I'm sure corresponds globally throughout the diaspora. My particular um, understanding of how sickle cell can be managed is through nutrition. I think the standard American diet is having a disastrous impact on everybody, but more of a magnified impact on the sickle cell community. Because
Christian, can I ask you really quick? You mentioned that it's hard to kind of you're being advocate and parent for your child. What was it like when you found out your child had sickle cell? What was that moment like? Can you take us to that moment? What it felt like?
so it was a genetic screening with my wife and I,
Mhm.
and there was a European migrant who was really just telling us that this was going to be something that we needed to do because there was a chance that our child could have sickle cell. I guess she just looked at us and thought that we could have sickle cell, which is also eugenics in nature as well, when you can just look at somebody and predetermine what their genetics can be. So we ended up doing the gene therapy, or not the gene therapy, but the genetic counseling through Kaiser, And initially they say after the child is born, that the fetal hemoglobin has to come out of the blood so they can actually see if the child has sickle cell or not. But after taking our DNA or our blood, they came back and said that we both had the sickle cell trait. So there was going to be a 1 in 4 chance that our child would have sickle cell. And so they had a standard of care that they presented to us, which was going to be penicillin really for like the first 18 years. And then, blood transfusions and hydroxyurea. So some of those things didn't really, wasn't in alignment with how we wanted to take care of our child. So they called Child Protective Services on our family. And Child Protective Services came to our home. And, after a conversation with them about how we wanted to raise our child and what our plan was, they didn't really take it any further. But I think the fact that, the institution or the hospital, the doctor's office, could wield that kind of power through, intimidation, creates a very hostile environment for children to even seek, you know, advice from doctors because it's, in a sense, there is some intimidation there as well.
Well, I think it's important that to note that it's it's like almost like a team. So it's like there's the importance of the role of the patient advocacy, the providers, and the researchers. So everybody works together, as far as all of it, like, and not just even talking about just sickle cell, but in every aspect of healthcare. I'm trying to think of how to how to really describe it. But I do want to jump really quick. We've got a couple questions in the comments. Um, Someone wanted to know, and this is for the doctors. I'm sorry. Can you describe what a typical sickle cell patient? Um, I guess they're asking what makes it so an underreported disease in comparison to other diseases, which I think we touched a little bit about. You know, why the Black community seems to be prevalent to it. But can we talk a little bit about that? Um, what is that typical sickle cell patient like? Like, there's not a specific look. There's, we've talked about the blood and the vessels and all those things. But what makes it an underreported disease in comparison to others?
Well, I can just comment that there is extreme variation in the symptoms and lifestyle of patients with sickle cell disease. So some of them actually do very well. They don't require transfusions. They have very normal lives, normal life expectations, and others do very poorly and require a lot of transfusions, a lot of treatment, end up in the hospital a lot, have a lot of pain, possibly stroke, etc. And I would say that we really don't have a good understanding of why they all have the same mutation, similar background, but for reasons that I think are at the priority of research, trying to understand what makes some of them on one end of the spectrum versus the others.
Okay. We've got another question from, and I'm sorry if I'm messing your name up, Marquai Barber. She says, hello. They say, hello from LA. Are there certified sickle cell care centers or places that are more familiar with this disease and how to treat it?
I think there are some centers that treat more than others. I believe there's a doc, if you're specifically asking LA, I don't know if they want peds or adults, but I know CHLA has a very large center. We obviously at Cedars, we have my partners and I will see sickle cell patients, and there is an adult hematologist that has a special interest in sickle cell. Her name's Dr. Hannah Lee. The Martin Luther King Health Center has a doc that is pretty dedicated to adult sickle cell care. I was saying before we got on that Harbor UCLA, one of my colleagues from my fellowship training is down there, and she has a pretty big ped center. and also has transitioned to seeing some of these adults, because a lot of times it's really hard to find, particularly in adult medicine, to find a doc that takes on a lot of these hematology cases just in general that are not a malignancy. It's hard. Benign heme is kind of hard to find in the adult world. So I know she's working with some doctors to like transition care and take care of some of those young adults to make sure that there isn't a gap.
Okay.
I don't know about the rest of the country. I know
Yeah.
got a
Yeah.
big center, like a really well-known Washington University in St. Louis is very well known for their sickle cell work.
Okay.
A lot of the major places that nationwide that you've heard of, so Duke, University of North Carolina, Columbia. These are just some of them. There's Children's National. A lot of them have large sickle cell centers where they see hundreds of patients. Part of it is due to demographics. So in centers where there is a large Black population, then there's going to be more sickle cell patients, and therefore there's more centers that have come up to care for those patients. In areas with do not have a lot of Black patients, you don't see as many, so there's smaller centers. So there are some areas in LA, when West Hollywood does not have a large African American community, and so we see fewer patients than in lots of other areas, like MLK. MLK has a lot. Yeah.
Okay.
USC they see quite a few.
So are there new treatments, Dr. Gibb, or clinical trials available? And how can Black patients gain access or learn more about those?
Yeah. So treatments are basically, they're in two varieties now. So there are these disease modifying medicines. One of them is hydroxyurea, which we've talked about, which is probably the mainstay of medications that improve the fetal hemoglobin levels and have, that's the number one probably drug that most patients should be on. There are others that have sort of come and gone that have different effects, something called L-glutamine. There are a couple others that were thought would be successful, have been pulled from the market, etc. One other treatment that is mainstay is transfusion. So, if a patient is not transfused, 95% of their cells will have the mutation, and they can sickle. The hemoglobin polymerizes. That causes a lot of issues for most patients. The transfusion can decrease those sickle cells so that they're only, say, 20 or 30% of the cells, and the other, bulk 75% of cells are from donors who do not have sickle cell disease. So that has been maybe also one of the most effective treatments. There are complications to transfusion, like iron overload, and there are some other complications which we can talk about later, like your immune response to getting a transfusion. But all in all, transfusion has been transformative for patients with sickle cell disease. And then there's another category, the newer category, which is gene therapy. So I think it was mentioned, Kristen earlier mentioned about CRISPR and Cas9. So there are two FDA-approved gene therapies. There are others in clinical trials, but there are two. One of them works by increasing the level of fetal hemoglobin, which does not have this mutation that causes sickle cell disease. That was approved in 2023. And there's another one, which is basically gene addition, they call, where they're just adding genes that encode the normal hemoglobin that don't cause sickle. Both have had varying levels of success. So when you talk about a cure for sickle cell disease, really gene therapy is the only cure.
Bone marrow transplant in pediatrics. In adults, but bone marrow transplant in pediatrics is curative.
Right. So sorry, I misspoke. So
well,
they've been doing
in
bone
my
marrow.
world, you have to be pretty young, to be able to tolerate it because they get too old. They're too sick. They have so many other complications, like you pointed out, from strokes and kidney damage, and they can't undergo that. So I agree with you. The gene therapy, when you speak to folks that treat bigger people than I do, it's revolutionary, but there's also a lot they're new drugs. We don't have a lot of data long term on them.
Yeah, so gene therapy is a type of bone marrow transplant. So
Yeah.
they've been doing, as you know, they've been doing bone marrow transplant for patients for sickle cell disease from siblings, et cetera, for, what would you say, 25 years or so?
I think the first person was treated for AML at St. Jude's, who also happened to have sickle cell disease, and that was, I believe, in the 1980s.
Okay,
and I think they did a follow-up with that person in the last data that I found, I looked this up like a year and a half ago, and I think it was like 2014, and they were still alive, and the sickle cell hadn't come back.
Yeah.
Now, what are the late effects of that? And, that also is a cancer diagnosis, but, and I can't remember how old they were. They were little, though, because it was, a pediatric patient.
Yeah. So you can do allogeneic, meaning from one person to another. Bone marrow transplants is, usually sibling to sibling, is the most common, and that's been going on for a long time. It's been very successful. The issues mostly in pediatrics, and the difficulty where gene editing or gene therapy comes in is in adult patients or patients older than 12, and they're using their own autologous, their own stem cells, basically, and then editing their DNA in a way so that they produce fewer sickle cells. So that's been the newest sort of FDA-approved cures, I would say. So.
And it's, sorry, I didn't mean to interrupt you.
Yeah, that being said, that there's, we were talking a lot about access to these therapies. So the new gene therapy, to have one of those new gene therapies, it costs at least $2 million, if not more. There's also a lot of conditioning that has to take place. So patients have to get a red blood cell exchange. They have to have chemotherapy in order to remove the prior sickle cell stem cells. And then they have to have lots of transfusions in order to support the engraftment of the new cells. And there are complications that can happen. So it's not a simple, one-day process. It's access to it is a problem for patients, who just can't afford it. So.
And then you think about, when you were asking about studies, when you look at how many trials have been available for folks with sickle cell, there haven't been. I mean, I think hydroxyurea was first, approved in the 1960s for cancers. They, realized that it increased hemoglobin F, it decreased some of the inflammation. It does help. The backbone of our treatment, but there was no FDA approval until 1998 for adults, and it was not approved in pediatrics till 2007.
Wow.
That's crazy. And then the next studies were the L-glutamine, I think was 2017, and then there were 2 drugs, one of which has been pulled from the market, that were like in 2019 or 2020, and then these 2 drugs. So we're talking, what, 5, 6 drugs? Something like in that ballpark that have FDA approval for this. And look at how many people it impacts. It's not been studied enough. And I know that at least the American Society of Hematology, and I think it became a higher priority within the NIH. And that's why when you look in the last 10 years, the numbers have gone up. And if you go to clinicaltrials.org or .gov, it's the government's website where you register trials, and you can search and say, I'm this age, I'm looking for this kind of a trial. You can find them. Now, they're not all screened by the government, but they're registered. And so they're usually universities or physicians that have that. So it's a way of looking for those things. But it also, I think, and I'm probably not the right person to speak to this, but it goes back to historically to how were people of color treated, how were like the simplest, trials. And of course, there's going to be some hesitance to want to enroll on a trial and trust someone.
Mhm.
And I can understand that from a patient perspective as to why there would be like, are you going to be treating me fairly? Like, do you have my best interest at heart? But if we don't do trials, we're never going to have better answers.
Right. So that was actually my next question. I'm glad you brought that up because we do talk a lot about here on blackdoctor.org about, that mistrust, that historical mistrust. So what can you say to the patients to, obviously you mentioned, we need the clinical trials so that we can help people. But if they're still kind of like, I don't know, what kind of advice can you get them to kind of ease their worries?
I think what I've talked to with families is you don't have to do it. I'm not going to treat you any differently if you don't want to do a trial that I have to offer. I'm going to give your child the best care that I can with the knowledge that's available, and go home and think about it. I'll print out a consent. I'll give you, if you want, if I have more patient information, if there's trials that I can help you look up or you can look up on your own, talk to your family. I don't think anyone should be pressured to do a study because that's coercion and that's not right. So I think I think it's unlike something like a cancer diagnosis where you're kind of on a time crunch. There's a little bit more time to think about it. Like, come back in a couple of weeks, come back in a month. We'll talk about it more. I think that would be not an advantage of sickle cell, but it's not like you have to decide now I'm doing this or I'm not doing this. You can think about it. And I think that giving people time to do their own research, to maybe get a second opinion. I really feel strongly that if a doctor is offended by a second opinion, unless it's a major emergency,
right,
maybe you need a different doctor. Like, I expect people to want to talk to somebody else. So I think it's just trying, at least, I don't know if that makes people feel better, but I just don't want them to feel pressured.
Yeah, I think that probably does relieve, because it's like, oh, they're pressuring me into I have to do this or I have to do this. So I think it's helpful to hear, in this situation, there's no pressure. You have time to think about it.
Yeah, I mean, I totally agree with what Dr. Baca said. I do find that there's a lot of variation in their willingness, patients' willingness to be part of trials. And, I've done small studies here, not a clinical trial, but we are taking samples from patients with sickle cell disease, and some of them are very enthusiastic and one of the reasons that they say they are is because, sickle cell disease is tremendously understudied. So when you look at various data of looking at based on the amount of people who have sickle cell disease, how many dollars or NIH dollars go into trials or just studies of sickle cell disease, it's disproportionately very low. And although it's improving, I believe, because of initiatives from the NIH, and ASH as well, American Society of Hematology. But it's, for whatever reasons, not studied to the same degree as other diseases. And some think like some are very helpful, like, please, if you can have research to do this, that would be to help us or help the next generation, then they want to do that. But then, there's variation. There are others that are quite hesitant. So.
We do have a comment. Janet Leacock Williams, she said she just happened to stumble on this live. Welcome. She says she's a sickle cell patient and will be celebrating her 70th birthday in December. Happy early birthday. And
Wow.
She says she's assuming there are no clinical trials for someone of her age because she's never done a trial in her life.
You may like them up.
Yeah. Yeah.
I was looking this morning. It looks like there's some new drugs, but let me look in the age group. She may be out of the age group, but they have an older adult section. So let's look.
Oh, might be in luck, Janet.
There are looks like there are some studies at clinicaltrials.gov that are actively recruiting and that didn't exclude over 65.
Wow.
So
Okay.
they may not be treatment studies, but they may be more of the things that like Dr. Gibb works on, that's like important biological data and things that are going to move in, that will move into treatment studies eventually with that knowledge that, you know, researchers like Dr. Gibb can gain for the whole community. So some of it was that kind of stuff, like understanding the natural history, like acupressure. There's one on that. Oh, very cool. Using acupressure for this.
Yeah. I hope that helped, Janet. She says, really? So let's see. I did want to, let's see, there was another question here. And there it is on the screen for everyone watching, clinicaltrials.gov, so that you have it. Janet, there's the website. It says clinicaltrials.gov. Just go to the website. And what will she need to do again, Dr.
You have
Bachman?
to search like the disease, and then it'll open up probably hundreds of things, and then it gives you from all over the world. So then you can narrow down to this area, or, you know, the United States. And then it also has like, if there's, you know, certain age ranges, or if you want to do certain types of trials, like medication or epidemiology or biological, like blood samples and things like that.
Okay. Well, what should patients and parents look at when they're trying to find the right physician? Because you mentioned a few minutes ago that, you know, sometimes you do have to go get a second opinion. So what should someone be looking for?
I think you want to make sure you have someone who's competent. So looking at their training, probably most big centers that you go to, the people are going to have the proper training and experience. That is going to vary based on where you train, though. Like I trained in Orange County, California. Almost all of our sickle cell patients were Hispanic, which, as Dr. Gibb pointed out, is the opposite of pretty much everywhere else in the world. But there was a large population, though. So I think looking at that and looking at, you know, some of it, you get to a certain point, like you meet a certain level of competence, and then it gets to, well, how does that person talk to me? Do I feel like I can ask them questions? Am I comfortable with them? And, you know, do I feel like I have their staff is easy to get a hold of if I have a problem? So some of it gets down to personality, that like, you know, I like this clinic because, you know, maybe you're someone who's like, I'm in this huge center and they have everybody you could ever imagine, or someone else may want to be somewhere smaller where I'm going to see the same people. They're going to know me super well. And I think some of it gets down to what you want and what you think would be better fit for you and where you're comfortable. Because I think you can make advantages and disadvantages in different situations.
Absolutely.
Yeah, I would just add that one of the issues we are very concerned about is when patients come to the hospital and they're treated by a hospitalist, you know, and they're trained, you know, they can take care of sickle cell patients, but when they get discharged, a lot of them do not have a dedicated hematologist to follow them. So, you know, I feel much more comfortable if almost all patients with sickle cell disease have a hematologist. So, although primary care, you know, internal medicine physicians can take care of patients with sickle cell, they've been trained, but really hematologists are the experts, especially benign hematologists like Dr. Baca. And I think that is that's one of the main ways that they can make sure they're getting the proper treatment. So.
Okay. Well, Dr. Gibb, are there commonalities between sickle cell disease and lupus?
Yeah, so I think lupus is also a disease that disproportionately affects Blacks in the U.S. and other areas. And from my perspective, and this is getting a little bit into a research area, but lupus is an autoimmune disease that's very inflammatory. You can have complications in basically all parts of the body. And sickle cell disease is probably the most inflammatory disease that exists that I know of. So inflammation in general, you know, that's sort of like where those two kind of diseases interconnect. So a lot of them have increases in whatever inflammatory factors that you're interested in. Lupus is a little bit different because patients make a lot of autoantibodies. That's what it is. Sickle cell disease, although those patients have a little bit increased chance of making autoantibodies, it's really more about the sickling effect and the vascular inflammation and the closing of the vessels and getting blood and oxygen to the end organs. So obviously they're different. One thing, if I'm a transfusion medicine physician, and so transfusion is a major treatment for patients with sickle cell disease, as we talked about earlier. It has the complication of iron overload. There is a procedure called red blood cell exchange transfusion, which allows basically removal of the sickle cells and giving donor healthy red cells at the same time in a continuous fashion, and that removes the risk of iron overload. So there's that. But also, patients can make their immune response can be activated by getting a transfusion. So you can think of it like a transplant. You're getting blood from somebody else. Certainly, it's going to be the right blood type. Otherwise, we have a very serious problem. So it's going to be O positive if you're O positive. But you can make there are many other things on a red blood cell that are foreign to you. So you can make basically an immune response or antibody response against those pieces of the red blood cell, and they can be very detrimental. So because one is that patients with sickle cell disease are the one population that has the highest frequency of making these antibodies, and many of them can make antibodies against not just one protein or factor on a red blood cell, but can make it against 5, 6, 7, 8, 9, 10. So when you get blood from the blood bank, they're going to give you blood that doesn't have any of those proteins that you have made an immune response against. And therefore, sometimes it's so difficult to find that blood for that patient that they cannot find compatible blood. So either patients with sickle cell, we try not to transfuse, so they become very anemic. That can cause problems, as you can imagine. Or we give them the best blood that we have, and then you have a risk of having what we call a hemolytic transfusion reaction, which can be fatal. So, that's one of and just to come back to lupus, the number 2 population that has the highest frequency of these immune responses is lupus. So, and they're both inflammatory diseases. So part of my research is interested in understanding how inflammation increases the immune responses of patients with sickle cell disease or patients with lupus that make these immune responses such as they get a blood transfusion. And if you can prevent them from making that by giving them intervening before, giving them blood that's better matched for them than just the random, what we typically do for other patients, then you can prevent them from making these immune responses, and then you don't have these complications like transfusion reactions and not being able to find the compatible blood for them. So that's, in my little world, that's the connection I can see, between lupus and sickle cell disease.
Thank you. Thank you for that explanation. We do have another comment in the chat. Nikita Roberts, she says, "Good evening. I live in Grenada, that's in the Caribbean, and are there any trials that she can take part in because she's 47?"
Look.
Yeah. I mean, I don't know the age limitations for the gene therapy. So a lot of there are clinical trials for disease modifying medications as well, because that's a huge gap. Like Dr. Baca said, we only have hydroxyurea, L-glutamine. There have been a couple others been removed from the market. So I imagine there are probably trials that they could be involved with. And also, you know, the gene therapy, I don't know what the age limitations on there, but I don't think 47 is too old. I haven't seen any studies that
I don't think
exclude
it's,
people. Well,
I think it's
or
60s.
maybe I'm wrong about that. Yeah.
One of them I think is a little bit, that's beyond my age range. So
Okay.
it's not letting me search for, I'm trying to search for the Caribbean, but that it does have international. So I think I would still look at that,
Okay.
clinicaltrials.org or .gov, I'm sorry. There might be something in Puerto Rico too, if it was like a US thing and she could get there and was interested in that.
Okay. Hopefully that helps, Nikita. I think the link is also yes, it's also in the chat. It's clinicaltrials.gov. So this question is, let's see here. So obviously today is World Sickle Cell Day. What is one thing, and I'm just going to go around and let you all answer this one. What is one thing you want the Black community to walk away with knowing or doing differently? Dr. Gibb, I'm going to start with you.
That is a tough question. You know, I think there's several things. Make sure that you're seeing a hematologist regularly. These disease-modifying medications that they provide, like hydroxyurea, do make a significant difference. So I'd be vigilant about, you know, if your hematologist thinks that is needed, that I would certainly do that. I would also, you know, I talked a lot about some of the complications with transfusion. I want to make sure that I do say that transfusion is unbelievably safe. There are so many regulations that we have to abide by. All blood is tested for, you know, infectious diseases. The chances of getting a HIV or hepatitis from getting a blood transfusion is one in the tens of millions chances of getting that. So I want to make sure that, you know, because sickle cell patients have, you know, many of them get transfused. They have sometimes hundreds of times. That it is still incredibly safe. So I would not, you know, be too worried about getting transfusions. One of the complications is iron overload, and there are drugs to prevent iron overload or to treat iron overload. Iron is a major problem for patients with sickle, and definitely, you know, if it's decided that you should go on to a iron cheerleader type medication, you should definitely do that. You know, if you're having, I would finally say, if you're having lots of pain crises going into the hospital multiple times in a year, or you've had a stroke, something called red blood cell exchange transfusions is something to discuss with your doctor. And they should know about this, obviously. But that's becoming more and more common rather than getting, you know, simple transfusions, which is just simple meaning just getting a transfusion. So I think that those are a few of the things that I would, you know, leave some of the viewers with.
Okay. Dr. Baca, how about you? What's one thing you want our viewers to walk away with knowing or doing differently?
Well, I think probably, and I think what I've seen for most of my patients is trying to advocate for yourself, which can be scary. It can be scary when, you know, you're in a totally different field and then you're coming into some doctors. It can be kind of intimidating. So making sure to advocate for yourself, asking questions. You know, even when I go see the doctor, sometimes I think I should write down so I don't forget what I wanted to ask, you know, because you forget in the moment. So those types of things that you can make sure that no one's going to remember everything, but prepared to ask the questions you want to ask. I think general health things, a little bit more in general. You know, sickle cell disease does make it so you can't concentrate your urine as well. So making sure that if you have sickle cell, you're drinking lots of fluids because you have a higher risk of like dehydration. Healthy diet, healthy weight, working out, and I don't mean we all have to be running marathons, but I think that's for anybody just in general. trying to move and walk and just be active. So I think those are things that people can do just for general health. And then just be, open-minded, go in with questions and advocate for yourself.
Okay. Christian, welcome back. I was about to come to you and I was like, wait, where'd you go? Welcome back. How about you? What is one thing from a parent, patient, advocate perspective? What is one thing you want our audience to know? Oh, we can't hear you. Nope, can't hear you. No, I'm not sure what happened. We'll come back to you when you get. We'll move on and then let you get that fixed. Let me see if we have any other questions here in the chat. I did see another one, but I've got to scroll up here to grab it. So there was a question about what can families in California do to address signs of disease or if the patient is diagnosed with sickle cell. That could be, I guess either of you could answer that while we wait for Christian.
I missed part of what you said. So
Yeah,
families in California can do.
Oh, okay. I'm sorry. They said, what can families in California do to address signs of disease or if the patient is diagnosed with sickle cell?
I'm
not sure if the question made sense or not.
like in an acute pain crisis or in a. I just want to make sure I address what they want me to or want us to address.
Right. It doesn't really have any other details because their next question was about diet change and would it impact sickle cell disease in children and adults?
So I would say if there's preventative things, I'll attempt, and this may not answer how they want it. So I apologize if I'm answering that question not the way you intended to ask it.
That's okay.
So I think advocating and trying preventative medications to try to prevent some of those disease issues that can happen. Like Dr. Gibbs said, stroke is a big issue, and there's silent strokes that happen in these young folks, and the numbers just go up as you get older, and it can impact learning. Obviously pediatricians, we focus so much on development and learning and making sure that we can reduce those risks in these kids so that they can grow and be the best, live up to their full potential, that everything that they can do, they do. So I think kind of preventative medicine is applicable with, looking into treatments that are available. And then during the pain crises, I think, it's hard because I think there definitely is a lot of, to be frank, racism that is felt by this community. Because when you're in medical school and you get training, someone walks in and says, I need X amount of milligrams of
Can you hear me now?
Yeah.
Oh, yes, we can hear you. Thank you.
You're trained in the ER. Oh, they're probably just drug seekers. Well, that's not this population. They've been dealing with pain since they were babies. They know. So I think it may be easier if you're, have your one center and you go to that center and then there's records and it's. So I think that may be helpful if there's someone like an acute crisis or, like my patients can call me and I can, bypass some of that and help say, no, I know they're coming in. This is what they're going to need. Please try to fast track them. So I think, those kinds of things may be helpful, but it's definitely something that's faced by this population that isn't faced by a lot of other populations.
Yeah, that's something we discussed on my show last week. I had a patient with sickle cell, and he talked a lot about when going through a crisis, going to the emergency room, and he was saying that it is important to let your physician know, that you're going so that they can maybe, whether it's call ahead or whatever. So I think that is a very crucial piece. Let's see.
Why reinvent the wheel? Like, if this is going to work, why don't I just start with that?
Mm-hmm.
If it sounds like a reasonable dose, it's not something too crazy. Like,
right.
that makes sense. But I know these patients, so that so I think that's where having someone help to advocate on the other side.
Yes, absolutely. Welcome back again, Christian.
Oh, glad to be here.
Okay, so as we're wrapping up, what was, since this, like I mentioned, it is World Sickle Cell Day, and what's, from your perspective as a parent that has a child that has sickle cell, and as an advocate, what is one thing that you want our viewers to know and take away?
So, the father of Western medicine is a man named Hippocrates. And one of the phrases that he coined was, let the food be the medicine. And I think Western medicine has veered very far off of that path. So I will say nutrition really should be the go-to for people of the sickle cell community, because the standard American diet these are food-like substances that we're eating now. And the impact that it's having on our bodies is disastrous. And so my son, 12 years old, hasn't had a sickle cell crisis in over 7 years. And I owe a lot of that to his nutritional plan. I mean, SS is supposed to be the most aggressive, the worst, one. And, we use moringa on a daily basis. We utilize the African yam, plant-based nutrition, vegetarian, don't eat McDonald's, stay away from processed foods, drink coconut water, stay hydrated. Eat your watermelon, eat your apples. And, we have to have a paradigm shift out of we're in a system, right? And the system functions a certain way to mistreat a particular group of people. And it's been doing it for over 400 years. And so I think it's very dangerous for us to consider the idea of outsourcing our DNA, outsourcing our bone marrow, outsourcing our genetics to another community, right? To correct, right? You're going to correct our genetics. That was the whole basis of the eugenicist movement, was genetic correction. And so we're seeing it repackaged and presented in a different way now, but it's still the same end result.
I'm sorry, I have to jump in because we're out of time. But I want to thank you again for reminding people that eating healthy, it does wonders. Thank you for that, and sharing your journey with your son. And I'm glad to hear he hasn't had any like sickle cell crisis episodes I'm not sure if they're called episodes, but a crisis in the past 7 years. That's amazing. Thank you, Dr. Gibb and Dr. Baca for joining us. We've talked a lot today about recognizing the historical perspectives and how it has impacted even, whether or not there's trust going into a clinical trial. We've talked a lot about all of that today. In the comments, everybody, thank you for all of your comments today as well. And now, if you or your loved one is living with sickle cell, know that you are not alone out there. Support, advocacy, and resources are available. So for more information, you can also visit blackdoctor.org and check out organizations like the Sickle Cell Disease Association of America, the Sickle Cell Association, and the Sickle Cell Disease Foundation. They're all working to improve care, raise awareness, and push towards a universal cure. So I want to thank you all for joining and sharing your perspectives tonight. And let's see, I think that is, yes, I wanted to make sure I got all the websites. Thank you all again. This has been a great chat. And don't forget, everyone, clinicaltrials.gov in the chat. Have a good night.